So today's Digital Humanities Colloquium is by Hanél Duvenage, Data in Healthcare Efforts, Digitization and Digitalisation. So I think this is a somewhat different topic from what we normally have, and I think it's going to be a very nice kind of different view of what digital humanities can also be. Hanél is a part-time research assistant and research project coordinator at Safako Makoto Health Sciences University, and the research and development manager at Safe Surgery South Africa, FPC. She holds a particular interest in the application of data science and bioinformatics to facilitate medical research. She holds two MSc degrees, one in medicine, specifically molecular nutrition and bioinformatics, obtained from Örebro University in Sweden, and one in nutrition obtained from the University in Pretoria in South Africa, of course. So I'm very much looking forward to this presentation. I'll stop my share now, and then now you can take over. The virtual floor is yours.
Perfect, thanks. If you can just let me know if you can see my screen.
Yep, that all looks
Perfect.
good to me.
All right, thanks so much. And thank you very much for the opportunity to speak here to everybody today. It's a topic that I'm very passionate about, so it's always nice for me to be able to share a little bit of what we also do and are busy with different groups of people. So yeah, as you've mentioned, Menno, my topic today is going to be regarding data in healthcare, and I suppose a bit more specific, the access to data in healthcare and how the efforts of digitization and digitalisation can help those the access in data, as well as the challenges that we are facing in introducing this specifically within the South African and African context. So just a brief outline, I'll mostly focus with the presentation on a specific project that we conducted in 2023 on paper record digitization, and looking a bit at the background and the methods we used there, the challenges we faced, and some future thoughts and directions we are looking at. But before I go into that, I just wanted to take a little bit of a step back, looking a bit at digital health, access and challenges, and mention one or two other perhaps projects in context, to just place it a little bit in context, looking at the different levels in which this can be approached and is approached currently in this space. As I also know that I don't know if a lot of you are well versed in the digital health aspects of everything. So yeah, if there's any questions, please feel free to let me know, and I'll try my best to answer them. So then just looking at digital health as a concept. So from the WHO, in a very, very simple definition, we're just looking at the application of digital technologies to improve healthcare and health outcomes. And this can include the development of new technologies or the use of existing technologies in other areas and applying them to healthcare. And this, incorporates the use of tools to improve health outcomes or health systems, make it more efficient, make it more sustainable, and enabling overall good quality, affordable and equitable healthcare across the board. But this is something that has been very challenging to attain, and specifically for low and middle income countries. As well, there's also been challenges in high income countries, but a lot more so in our setting. And I'll go into that in a little bit more detail later on as well. But before I get to that, when I talk about data access, and this is by no means a full comprehensive analysis of everything, but it's something that's in my day-to-day I deal a lot with in terms of the different levels in data access. And when we look at, digitizing or digitalizing systems, this is typically levels that we are considering when we're looking at this field. So first of all, looking at a very small team level, looking at patients communicating directly with their surgical teams, their doctors, their physicians, their anaesthetists, and how we can improve access to patient information for the doctors, as well as information to patients about the surgeries that they're conducting, and how can we overall use digital systems to better communicate information from the patient to the healthcare team and vice versa. This type of data is typically very large data sets with a lot of different elements, looking at a lot of granular aspects, you know, a lot of specific questions for a patient about their health outcomes before and after surgery, looking if healthcare or if the surgical intervention or area health intervention actually improved that care. When you take a little bit of a step back, we're looking at more of an institutional level, looking at data at institutions, at clinics where health interventions often take place. These data sets tend to be a little bit smaller in terms of the elements we collect, but a lot more information, a lot more patients, a lot more surgeons contributing to this data set. And this helps to inform quality improvements on a facility level, looking at cost efficiency, looking at patient outcomes between facilities and comparing that and seeing where problems may arise. And then taking even another step back from that, I wrote their national level, but really it can be provincial, national, global, continental, a sort of a larger scale data set that we're looking at with elements that might be smaller that we collect or very specific, but using all this big data set feeding into it to inform decisions on bigger health systems, on resource distribution, and looking at how we can improve that. So when we talk about digitization and digitalisation, within these different levels, there's so many different things that are being done. And I can't in 40 minutes talk about all of them. So I wanted to focus on some of the projects that we are involved with before I go into the specific one, just to show you the different types of thoughts around this process of digitizing healthcare data and making it readily available. So the first project is the peri-operative shared health record, which is an electronic database that specifically focuses on a patient and their outcomes after surgery. So that's really speaking to that team level data collection, a patient being able to electronically log their outcomes up to a year after surgery, and those outcomes being able to report to a surgeon being able to see, you know, how his patients are doing, how much pain they are doing, is it normal to have that much pain, is there something he can do to improve his surgery, and just also in a very sort of one-on-one for a patient to be able to give that type of feedback to a surgeon, even a year later of the surgery when they don't necessarily even have that contact anymore. So that's really on a team level. The second project that I want to talk about is the DHIS2 tracker project. And this is really looking at that sort of national, provincial level of data collection. It's currently looking at the feasibility of recording real-time data electronically on a hospital level. And this is something that might be done in the private sector, but within the public sector, this is a very large gap, and very simple indicators or that you'd think is routinely corrected, like the number of surgeries done in a hospital, is not as readily available as you might think. And being able to record this real time, having good quality data feeding back immediately into a database on a provincial or larger level can help with, for example, resource distribution, how much is needed at which facility, how much patients are they seeing, what is their outcomes, and how can we assist there. And then the last project is the eSearch project that I will be going on in a little bit more detail later, so not saying too much now, but this is really looking at the digitization of paper records at a hospital level and looking at how that can be extracted from, or how information can be extracted from routinely corrected records on paper and analyzed to help improve outcomes. So before I get into that, there's also a myriad of challenges in this whole area of data access and accessing healthcare data across the board. And again, by no means a comprehensive list, but things I just want to highlight specifically is firstly the data silos and interoperability of data. So I mentioned briefly before that there are a lot of different systems existing that people are using, and a lot of efforts being made, but the problem is that so much of that is occurring in silos within very specific groups, a surgeon recording his data and only his data electronically, or a hospital group recording their data, or a medical aid recording their patient data. And none of these talk to each other. One, because not necessarily they're able to talk to each other, they're not developed with a single goal in mind, and they can't be aggregated to be able to collect all of this data and pull it together to help us inform bigger decisions on this data. And also because of things like trust. The trust not existing between a doctor and a medical aid, for example, and how we can approach that. And that's a very difficult question to answer, whereas interoperability might be a little bit easier to do, working on things and engaging with people and creating that type of trust to be able to share all these different types of data is really important to do, and not as difficult, not as easy to do. And then when you're looking at digital tools, there's always an issue of user acceptance in various different formats. For example, the patient platform that I mentioned, is it in a language that can be used by or is understood by the patients? Is there perhaps voiceovers for people that aren't literate or that cannot read? You know, is it accessible even without internet access? Because that's often a big problem, that we don't have internet access. A fear of technology, and this comes in both with patients and with doctors, and not necessarily fear, but an opposition to accept new technologies. If something's been done the same way for 30 years, people are opposed to change. And these are just some of the things that we are struggling with when we're trying to introduce these new technologies and tools to help digitize data in healthcare. And so getting into the specific projects in a little bit more detail. So I refer to it as the eSeach project, but the full name is really the Smartphone Artificial Intelligence Platform for Paper Record Digitization. And this is a project that we started in 2023. And it's a collaboration between 3 universities. So it's SMU's, Wakamakata Health Sciences University, where I'm based, the University of Virginia in America, and they're the ones that developed the AI tool to extract the paper data and make it digital, and then also the university in Rwanda, who was also one of the testing sites for this. And what we aim to do is really to test this application that was written specifically within the African context. As I mentioned at the start, it's been difficult to attain a baseline for digital health within this context. And I'll go into some of the reasons now, and also show why it is so important for these technologies to be introduced within our context. So when we look at data in healthcare within Africa, there's major gaps between high-income countries and low and middle-income countries in both access to surgery and outcomes after surgery. And surgery in low and middle income countries is typically characterized by disproportionately higher rates of complications and deaths. Patients in Africa are twice as likely to die after surgery when compared to the global average, even though the risk profile for this population is quite low, and the procedures are not necessarily that complicated. A study that I've been involved in showed that 95% of deaths that occurred in these patients in Africa occurred post-operatively, so after the operation took place, and was actually considered preventable. And there are multiple factors that determine these outcomes of patients after surgery, but a key approach to decrease mortality and these complications is the ability to predict the outcome of a patient before they go into surgery, using trajectories or pathways from data collected before and during the operation, because this allows us to identify patients that deviate from these pathways and assign resources that are often quite scarce early and efficiently to the right people. And this can help us to reduce mortality by enabling a closer monitoring and data-driven resource utilization. So just before I continue, I feel I need to also acknowledge the very important work that the African Peri-Operative Research Group is doing. And one of the study I mentioned earlier that showed the death rates in Africa versus the global average. These are all studies done across the continent with clinicians as researchers, with a vast network of thousands of people contributing to these studies. So getting back. So what is needed? What are we looking at when we're looking at trying to predict risk of patients and in order to improve their outcomes? What we want is to be able to automatically identify patients at the highest risk of deterioration, using, like I said, data from before and during and after operation, so that we can immediately allocate these limited resources. And then Secondly, we should be able to provide actionable clinical guidance to these care providers on what is required for this patient. How do we help this patient? And ideally, the system that we're looking at should be able to capture and digitize peri-operative data, so data from the whole operation from before, during, and after, even in very, very limited resource hospitals, because that's what we're sitting at within the African context. Being able to transmit the data that we see real time on the ground to a location where there is sufficient ability to compute these risk predictions and immediately return these results to the provider. But of course, everything isn't as easy as we would like it to be. And so when we're looking at predictive analytics, they require a lot of machine learning approaches for algorithm development. And one of the biggest issues we have is that we do not have a comprehensive database for peri-operative data from low, middle income countries that can be used to train these types of models. It is not data that is aggregated and exists that we can use and to help inform these decisions that we're making on patient care. Capturing and digitizing this data is very challenging as well, because a lot of the countries within Africa that has a high need, all of this clinical information is still collected on paper, in surgical case logbooks, in paper theater registers, and things like that. And only really when research is being done is there any effort to digitize some very limited data elements within everything that is collected. And so while all these digital health solutions are needed, the adoption and the implementation of these solutions has been slow for a lot of reasons, including the cost of these systems. Building them and maintaining them, hosting them on cloud-based servers, all these types of things cost a lot of money that is not necessarily readily available to spend on these systems. A lack of trained, for example, IT personnel to implement and maintain these systems, and a lack of standardization. And this comes sort of in two components. One, in terms of definitions that we use when we're looking at surgical procedures, and secondly, the monitoring equipment that are using is not necessarily always standardized to be able to provide accurate and interoperable data. And evidence predictive models, and the last problem is that a lot of the models that exist, that has been developed and done in high-income countries where this data is more readily available, have never been validated in the low-middle income country setting, and we don't know how accurate it is to use these existing models within our settings. A recent study also showed, with that same group that I mentioned earlier, that the post-operative management based on simple pre-operative risk stratification, so not necessarily high-level modeling, but rather just simple risk calculators, did not actually improve outcomes. So this shows that we do need something more. We do need something a little bit more powerful to help us approach this problem. And so this specific study aimed to develop a database of peri-operative and outcomes data that we can, in the low-middle income country setting, using South Africa and Rwanda as testing sites, that we can use to test and train prediction models to help identify risk factors in patients early, so we can flag them, so we can help and improve their care immediately on the ground. This data set will consist of data from two areas. The first is medical charts that is routinely collected and filled in on paper in theater, while using captured images to collect this data. And the second one is outcomes data that will be electronically inputted into the system. And these two data sets will then be linked, creating this full database that we can be used, that is de-identified and can be made publicly available for people to be able to start building and training these prediction models. And so for a bit of a use case, so like I said, this data set will include all the information that's currently collected on paper records before and during a surgical operation, and linked to an extensive post-op outcomes data, recording all complications, how long a patient was in hospital, when he was he discharged to a different facility, to home, all these types of questions, feeding this into the same database so we can start looking at patient outcomes more comprehensively. And then this data set, like I said a few times now, can be used to test, firstly, test models that are developed already in high-income countries and validated against low- and middle-income country data that might be very different because we have different variables, different indications for surgeries, different comorbidities, etc. Or then to train novel predictive analytic models to identify high-risk patients within the system in a timely fashion. And so just briefly looking at the methods. For the first part of it, the paper charts. So the app we use to take a photo of the patient charts, and then with the team at UVA, they developed a custom-written smartphone app which can extract and digitize the data from these handwritten records to populate the data set. The data is encrypted and de-identified before it is transferred electronically. And the team there has really been, for 2 years now, developed this sort of technologies to deep learning image analysis approaches to extract this data, how it can be done, what are the pitfalls, and looking at the different types of data that can be extracted in such a way. And then maybe just to note, so 3 different types of data was extracted from these records. The first is text, so either handwritten or typed text on these charts. The second is checkbox data, and the last is graphical data, so plots that are plotted on these theater charts, for example, changes in blood pressure, changes in heart rate, which can then also be extracted and fed into this digital database. All of this data that is extracted from these images will then be pulled into one relational database, and that will be accessible to, like I said, it will be publicly accessible. And what is very important of this study as well is that it enables us to have a data set that is labeled, that is, it's not just figures and numbers coming and pulling in, but because of the way the charts are organized and because it's fed into the system beforehand, we know exactly what the numbers mean. It's not just pulling a 500 mol number from the charts, but it's actually putting it into the right box, showing us it was a medication and which type of medication this was used. And that really creates a lot of opportunities, and which was the hope, would make the process a lot more efficient in terms of trying to generate these electronic data sets from routinely collected data. And so this is just a quick photo that I have in here just to show you what the charts typically look like that's filled in on paper. So this is just a blank chart. And then what we did in the study was to take a picture of this, blocking out any of this whole block here with the identifiable information of the patient. And then, as you can see from the charts, there's different types of data inputted on it. So the boxes here, for example, would be handwritten notes by the doctors that would be extracted and put into this bigger database. There's, for example, here on the side, check boxes, as well as at the bottom here. Sorry, I know it's a bit small, that extracts text box data. And then there's not really a graph example here, but it looks sort of like this section here, where changes over time is plotted in a graph format and then fed into the digital dataset system. And so this is sort of the 3 types of data that we were looking at when we did the study. And so, unfortunately, we don't have a lot of results yet that I can share with you. I had hoped there would be a little bit more, but just to talk a little bit about what we have seen so far. So firstly, there has been a high accuracy for certain symbols and data points, for example, blood pressure and respiratory data. So this is sort of all the graphic data, as well as checkbox data. So all the data that's placed in the different checkboxes. Which is probably that we could have recognized or knew before, but it's still worth noting is that AI is not any better at humans at identifying doctors' handwriting. So that is one of the bigger problems that we had. We initially hoped that the text recognition would be able to get about an accuracy of 85%, which we saw was not possible when we did the study now over the two hospitals. But maybe just mentioning that the accuracy for these other types of the checkbox states and so was more than 90%. So that is actually quite good. And then the third point is there's still a lot of human efforts involved that was needed to, before we even started the study, to input these blank charts, to create the separate fields that's going to need to be pulled into. And because all the different hospitals use different charts and different systems, this was a very high effort process in the end. It's not as standardized or as easily standardized as we'd hoped it would be. And this would be prohibitive to, in the long run, be able to implement this app across the continent, being able to just give it to the different hospitals and say, you can use this to digitize your records, because of all the effort that needs to go in beforehand to make that possible for each specific chart. And then another issue that we saw was, I initially mentioned that we wanted to link this chart data that we're capturing with outcomes data, with extensive post-op outcomes data. But because this is also on different paper charts and also need to be manually inputted at this stage, that really just wasn't possible. So we ended up having to sort of create this data set that we're doing with very limited data, including just days in hospital, status at discharge, so if a patient was alive or if the patient died in the hospital, and really just being able to look at very basic outcomes. So some of the things we're looking at as the project goes on is to perhaps look at a standardized anesthesia paper record, where we can incorporate some of the key features that we're looking for, that's already routinely corrected on the specific records, but changing the format, and being able to distribute that so that we can much quicker and easier digitize it by using a standard system. And this would include incorporating things into the image, for example, anchor points on the four corners of the charts for the AI tools to be able to easily narrow down the area that they're looking at. Using more checkboxes to document data elements rather than text, because as I've mentioned, that is a big problem when looking at this, at the efforts around this, and using sort of with that pre-printed lists of common things, common drugs, common perhaps complications, that can also just be translated into these text boxes rather than having people have to write it out. Yeah, and then the segmentation for this physiological data is just having clearer gaps between the different areas of the chart that record different things to make it easier to pick up on the necessary information from those fields. And then I talked a lot faster than I thought I was going to do. So this was just some of the references that I used. Yeah, and then open for questions. Sorry, I think I rushed through this quite a bit.
Thank you very much for the presentation. And I don't think it's a major problem. I've got a whole list of questions.
That's good.
So we have some time for discussion.
Perfect.
I see that in the chat, Pete Masalela says, hi, if I want to participate in this useful project as a member, what should I do? Or starting this project collecting health data in my language on our local clinic by using Isindepele. But surely I want to participate fully in the project. So I think the question is, if you want to participate, or if you work in a hospital, I guess, you want to participate, what is it you want? What is it that's needed?
Yeah, so there are a lot of projects that are ongoing, and definitely much need for collaboration between a lot of different fields. Depending on the type of project you're looking at, if you're specifically looking at this last one I mentioned about the digitization of these health records, currently, it is all, for example, in English, and which it's just trying to extract that, but being able to use it, we're not there yet, unfortunately, at this stage. So that might be a bit difficult, but looking at projects with where we're looking at patient-reported outcomes, patients communicating to their clinicians. There's a lot of help needed from a lot of different fields. And there's a lot of projects ongoing. I mostly work with universities and the projects there. So if there's something specific in mind that you'd like to do, I'd suggest, talking to an academic hospital, because there's so many projects ongoing to help improve patient care, and they'll definitely be able to help you. Welcome to reach out to me if there's something specific you'd like to be involved in. If you'd like to start a project to collect health data, I mean, that's fantastic. The main part is just really looking at what you want to collect, or how you want to do it. So really, I'm trying to just organize my thoughts a bit now. It's starting small is really the main part. Starting small, looking at there's a lot of resources that I can share in terms of what data we've sort of been seeing is very important to collect, and starting on a very small local level, getting that data just centralized and just recorded routinely is such an important first step. And just having that data, so much of it is lost or is written on paper and get lost somewhere, and that's really limiting a lot of the impact we can have with these projects. So making sure that very small data sets, surgical volume, patient destination after hospital, just recording that, having it in a language that is accessible to the population you're looking at, and being able to just communicate that back is already a very big first step. I'm not sure if that really answers your question, but I hope it helped a little bit.
Did that answer your question, Pete?
Yes.
Okay.
In fact, the geographical area is not the same.
Yeah.
Where the language speakers of that area, they will differ from area to area.
Definitely.
Even in terms of what you call the health, what you call environment. But now I think collecting different information data, for instance, in Isindebele, around the area where Amandebele, the geographical area of Amandebele is situated, I think it will even help, because currently, as we speak, we are a little bit behind in collecting data in our language, Isindebele. And right now, I'm based at the University of Mpumalanga as a lecturer. That is why I'm asking this question, so that I can be fully participate and collaborate with the project manager of this project under SADILA. But then you have answered me, my professor.
Yeah, that's a good place to start. Yeah, and it's right what you're saying. It's so needed to have these different sectors and regions involved in this, because it differs so much. There's a study now in Brazil that they published, I think, at the beginning of the month, just showing between the different regions how different healthcare looks in that space, and that's with a similar language. So as well as the similar regions, a little bit less maybe diversity than what we know we have in South Africa, and being able to really show what it looks like helps inform us on different policies. One of the projects we're on now is also looking at all the different provinces individually, just trying to show how different it looks in Gauteng to the Western Cape to the Northern Cape, and the different issues and struggles we have, and the feasibility of just trying to digitize health systems and what it looks like. The challenges here and somewhere else is just not the same. So it's very important to have this from a very granular level and feeding into a bigger system that can help us inform and make these decisions that we need to make to improve outcomes.
Thank you, my prof. Well answered.
I'm not sure if there are any other questions. I don't see anything in the chat at the moment. Like I said, I do have a few questions. One I'll just jump in while people are writing their questions in the chat. So I was really curious, and this is a discussion that's been ongoing, at least in Europe, at least in the Netherlands. That's about kind of patient information security. So I mean, on the one hand, people see the benefits, I think, of sharing their information because it might help them in their recovery process, etc. But at the same time, it's very personal information that you might not want to have shared with some other people or organizations. For example, I'm thinking of health insurance companies, for example. There are some things that I might prefer that health insurance company not to know because that might affect my the costs of my insurance. So how do you handle this? How do you get say hospitals to share the information? And you mentioned that you kind of cover some of the personal information like names, etc. But I think the information that you do collect might already be so specific that you can identify who it is in a way. So how do you handle this anonymization of data, and how do you handle this data security that not everybody can access this data?
Yeah, that's a good question. And, you know, as I also mentioned earlier, trust is a very, very big issue that we're seeing with not just patient data, sharing it with medical aids, but doctors not wanting their data shared with hospitals or medical aids. And so all of this is really very relevant. It's sort of done in different ways with different projects, I think, in terms of what the real aim is. So for the latter project that I talked about, the digitization, that is very much aggregated data, and all the data that can link a person to a procedure has already been removed before this is even extracted. There's no names, there's no time, specific dates a procedure is done. It's a type of procedure and a length of stay type of information, and maybe a journey pre-operatively. So with real patient information, I don't think you'll ever be able to have it absolutely anonymized. If a doctor sees the data, they might be able to remember it was their patient. But I think when you aggregate it to, you know, thousands, 20,000s of patients, that sort of really eliminates the ability to pinpoint it in that sense. What is often a big problem that we're seeing with some of the more patient or team level responses, for example, the one we have, that we're looking at a team being able to share their information directly with their doctor. You want that personal communication between you and your doctor. If you want, if you don't want to use the platform, of course you don't have to. But if you opt in to use the platform, that's sort of what it's geared to do. So you as a doctor can see the patient and the patient can see the doctor, but then having that data not being able to transfer to anywhere else, you don't want to see it. So we're very careful in terms of when people sign up for these systems. It's very, very encoded and encrypted on, I think, 3 or 4 different levels on the back end. And only ever, you know, if it's used for research, only after all the ethical approval processes has been done. And then all identifiable information, all names, all times of surgery, all of that is removed. And it's really only looking at aggregating a level 10 pain score, a level 9 pain score after an orthopedic surgery or after a kidney replacement or something like that. But it is a big question, and it's something that needs to be done, and it's difficult to do because, like you say, you know, having a little bit more information available, you know, how long a surgery was, what time of year a surgery was done, which is typically data we want to exclude because it helps to identify patients, also helps inform other questions. And so there is a bit of a play-off in what you can and can't do in this, if that helps.
No, exactly. It is a difficult challenge. You want to capture as much as you can, but you also don't want to capture everything.
Exactly. And it's quite interesting. We're working with colleagues from Sweden as well now on a different project. And there a lot of the data has already been collected and aggregated to such an extent that it's sitting there ready to use, but people aren't using it. Whereas for us, we're now starting to build these systems and starting to collect this data. And for them, it's almost harder to anonymize all this data that's already there, because there's so many things going on and linking all these things together. Whereas with us, with the bottom-up build now, we have a little bit more control about all the steps if it's done correctly. But as well, the what do you call it, the reason for the studies and all of that also informs that. So yeah.
Yeah, no, I understand. I think people are still writing their questions. Oh, I see a question. Carolina writes, I was interested in the handwriting aspect of the data. I actually had a question on that as well. How much of the data approximately is handwritten? You mentioned that the computer has difficulties deciphering doctors' handwriting. Well, fair enough. Figuring out my handwriting is also
yeah.
But on the other hand, I heard some programs are able to learn handwriting styles and decipher them.
Yeah, so we were initially very hopeful that because they've also spent so much time building the system and incorporating these technologies to be able to identify and learn the different handwriting, that we'll be able to get a percentage of that 85% on reading the handwriting. But I think the difficulty in that is there's you know, with the state university hospitals that we're testing that in, this was with, you know, it's 20 registrars or MOs coming in, you know, and you don't write the same every day necessarily, and they are on rotation. So, you know, every 3 months it's a different registrar coming in and a different person writing. And I think that makes it really difficult for these technologies that try and learn handwriting styles to really be able to accurately predict that, because it changes so often and so many different people involved in writing these charts out. As for how much of it is handwriting, I think it's about 40%, if I remember correctly, but don't quote me on that. That is handwritten, at least on the anesthesia charts. Outside of that, everything's handwritten. So the anesthesia charts that I showed, that blue chart has some type field. So this helped a lot in pinpointing sort of areas where what type of data is captured, to help inform, you know, where that should go in the data sets. But outside of that, everything's handwritten. Theatre registers are handwritten, you know, dates, names, procedures, codes, all of that, you know, it's all handwritten. So that makes it really difficult when you try and extract this type of data.
Well, thanks. Rue raises a hand. Rue?
Yes, I was also about to ask, I was typing a question about handwriting, but I deleted it as I saw this question that came up now. But I just want to now ask, what sort of system are you using, or a tool that you're using to actually decipher or recognize the handwriting? Because I saw this, the picture that you shown, it looked like a normal PNG file, if I'm not mistaken. How then, what are you using to actually recognize, to make the tool to recognize the handwriting?
Yeah, so this was a tool that was specifically developed for this project by the University of Virginia team. I don't have all the technical details on that, I'm sorry. But they specifically developed it at their side and tested it internally, and then we used the same technology to try and see how accurate it would be to use in our settings as well. So I'm sorry, I'm not sure exactly what different types of tools they used for that.
Rue gives a thumbs up. So I was also kind of interested. So on the one hand, so I think it's interesting in this OCR of handwriting. On the one hand, it is very difficult to do, and especially with doctors writing. But on the other hand, I guess, but I don't know exactly what's in there. So perhaps you can say a little bit about that. The text that's there is probably very much terminology related, right? So it's not, you can't expect everything there. There are certain terms that you can expect. And I know, so at some point, this is years ago, I worked with a data set, a medical data set as well, with photos and text. So there were cases as well, and you needed to find similar cases given a particular case. That data set was mixed English and French, but there were areas where you couldn't even figure out what language it was because the terms were mostly Latin with a lot of typos. So this was already born digital. So we couldn't figure out what language it was, English or French, because there were so many typos, but also because there was a lot of terminology there. So how much variation is there in the text that is there? Is it, I mean, I actually expected the quality to be a bit higher, assuming that there is a lot of terminology there that you're just looking for.
Yeah, so that's one of the things that we're thinking of doing now after that is using areas like, for example, medication with standard names, common medications, seen to have sort of checkbox, because that was quite accurate, being able to pinpoint that, rather than trying to decipher a doctor writing cortisone, having it as a checkbox and ticking that. So that's sort of something they're thinking about getting around that, because like you say, there are standard terms, procedure names, category of procedure, it doesn't have to be written out. There's a set of maybe 20 we can use. And if you can tick it, that immediately eliminates that type of problem from there. And actually, I'm not even sure how much language is an issue here, how much different languages people are writing in this charge. And that might be one of the reasons that they saw that low accuracy. Because it's not necessarily because this was developed in America, something they thought about before, testing this in our context, where there's maybe 3, 4, 5 different languages that could have been written in these charts. So that's actually a good point.
Oh, cool. But your proposal is then to essentially change the forms, right? To make it more
so they're looking
standardized?
at more standard forms that can be used within this app that we're developing in the hospital setting, but also using, not trying to differ too much from what's already there, but maybe just adding different sections that they can to help, with sort of information they feel is the most important to have standardized, and test that in the settings next. So that's what we're looking at doing maybe next.
Yeah, cool. I see Sang Molapo, you have your hand up.
Yes, and thank you for the opportunity. So I just had a question around the ethical considerations concerning this data, and I wanted you to just, highlight a bit of what or whom did you leverage to sort of get access to the data? Because I understand you said it is abstracted and aggregated at a certain stage, but someone is required to actually do that abstraction and the aggregation. So I'm keen to just understand whether it was doctors who did this for you, or it was some people on your team, and how did you actually convince the parties, being the hospitals and whoever else is on the very end, to actually give you this data? Because I can imagine that they are not likely to just say yes when you knock on their door. So maybe just give me a bit of advice there, because it is something that one has touched on, and because of these ethical considerations and so forth, there was a whole lot of hurdles that came through. Thank you.
No, absolutely. And it also very much changes who you approach and who you talk to depending on the project. So for this specific one with the image extraction, we did get ethical approval from first the university where the study is conducted, saying that this will all be anonymized data, and when it's sent out, then you need to go to the hospital board. You need to get permission from them to actually enter theater and being able to take these photos. And then from the nurses itself in the theater. So there's a whole bunch of people going down to the list from who to get permissions for. And, this is all, specified in the protocol as to who did the actual data collection. So there's a team doing the actual data collection that takes the photo, and then they're responsible for sort of covering. So it's sort of almost easier in a way that you just need to cover that, and it's immediately not present at all. It's not digitally deleted later or anything like that. So it's not captured at all. And then that was quality control and checked with first myself before it sort of got sent into this centralized database. Well, first actually so it's the team members covering it, then every day that is sort of quality checked before it's submitted to me. That also quality checks that there's no identifiable information visible before it's sent to the universities. And they also didn't actually analyze that section of the chart just in the end as well, just to make sure that there is no data that's identifiable that gets out. With aggregated data, it's a little bit easier sometimes because it, it doesn't link to anything, but South Africa is also a little bit easier. Countries like, no, not Rwanda, but Tanzania and Uganda, their national ethics committees are extremely strict when it looks at data sharing in any capacity, and they require a lot of different data sharing agreements before any data even so much as leaves the country in any way, shape, or form. So with them, there's a lot of different steps also need to go to, and different regulatory approvals to get before they will allow any data to be transferred out of the country. So it very much also depends on the setting and the type of information you're collecting. But for this study, for us specifically, it was going through ethics and the hospital approvals, and then going through the theater teams with the ethics approvals and getting their approvals, they're checking that we're doing what we're supposed to do. We're checking that we're doing what we're supposed to do, before the data leaves.
Thanks a bunch. Makes so much sense. All
yeah,
right.
it's a difficult and long-winded process, but it's important. So
yeah, it's a headache. It's a headache.
Yeah, it's definitely, but I mean, it's patient data, so you can also understand why. But yeah.
Totally. Thanks.
Well, thank you. I'm not sure if there are any more questions. We have a few more minutes left. So I was actually really curious if nobody else is raising kind of a follow-up. How did you convince the hospitals to join? And what's in it for them?
So the one benefit of the hospitals we worked at is a lot of the hospitals that are linked to universities, and they were specifically chosen because it's a bit easier. Because it's linked to university, they're used to research taking place. So there's a lot of different research projects going on in academic hospitals. And so they're used to the process. They know, it goes through the university, it goes through ethics, and then the board itself also just makes sure that they're also happy with everything that's being collected. In different settings, that's much harder in private hospitals, private sector, or hospitals not linked to universities. That aren't used to research being done. You see a lot more hesitation towards doing projects and collecting data. It's a lot less, I don't know if trust is exactly the right word, but they sort of, they're not used to data being shared and collected and leaving the facilities. And so it's much difficult working in those sectors. With universities, because the hospital is used to different projects being run there, as long as it's ethics approved and they can see the protocol, it's usually then communicated down as well.
Yeah, cool. Oh, thank you so much. Okay, I think we're getting to the end of the colloquium, and I think it was actually good that we had a bit of time to discuss this, because there was quite a bit of things to discuss. No, thank you so much for the presentation and the discussion. I really appreciated it. And I think it's interesting also just to kind of think, for people to think about, where does my data come from? How is it handled? What are the problems? So even outside the hospital situation, I think there are more cases where this takes place. But thank you so much.
No, thank you. It was great to be here.
Thanks.